sort of we're going to be hashing out today this really important topic, and it's so great to see so many people here. So like close to 400 right now. So I'm Perry Halkitis. I am the very proud dean of the Rutgers School of Public Health. I'm also the Hunterton Professor of Public Health and Health Equity, and I'm joined today by my colleagues Rafael Perez Figueroa, Leslie Cantor, Bobby Lowry, and Quincy Belbillon, who will be talking about the manifestations of MPX, monkeypox. We'll call it MPX, and you'll see why when I would do my initial comments over the course of the next hour and a half. So to keep this interactive and interesting and lively, we have a few things that I'll talk about. We're going to be each of us will be just making some brief comments, but at the beginning of each session with my colleagues, we'll be doing a poll question to keep it interactive. If you have questions, and at any point during the conversation, please put them in the Q&A. I'll be looking at them. I'll be posing the questions to the group, and we will have a really awesome opportunity to just converse openly, honestly, transparently, without any pointing of fingers, hopefully, at the situation that we are facing right now in New Jersey, in the United States, and in the world. And having said that, let me start here by sharing my screen and going from the beginning. So again, welcome again. With our conversation, here's a picture of my lovely colleagues. So let me just tell you a little bit things about the webinar. As I said earlier, we'll be referring to the disease as MPX. We're going to keep the conversation going on Twitter while we're doing it here, also on Zoom. So you can tag us at Rutgers SPH. You can post your questions in the Q&A. Again, we'll be posing poll questions. If you wish to limit personal information shared with other attendees, please feel free to edit your Zoom display, and we will provide slides to everyone who is registered for this conference, for those slides that we have, so that you can have them as a reference. You don't have to worry about having to write things down. You know, as of this morning, this is the latest number we have, 7,102 confirmed monkeypox MPX cases here in the United States, constituting about a quarter of infections throughout the world. We are the epicenter once again of another pandemic. And you can see by the coloring across the map here the states that are most impacted. Of course, we all know that testing has been slow. This is probably an underestimate of where we are. We also know that we've just lived through Pride, and there's a possibility that will be a huge increase in numbers over the next few months. But fortunately, there are efforts on the part of the United States to try to get this under control. Well, I said earlier that we were going to be referring to monkeypox as MPX. The World Health Organization has also asked for this. The term monkeypox was coined in 1958, and it is believed to, and I believe it stigmatizes people of color and the LGBTQ population. So we don't want to stigmatize. We are, unfortunately, in our study, very good at doing that. But let's get it right from the beginning. The other thing that I want to point out here to you is that if we look at this particular chart on the left, and I take every opportunity to talk about intersectional identities and about the idea of a syndemic and the idea of social and structural inequities, what you will see right here is in purple, or in some kind of version of violet, the percentage of the population across race and ethnicity in the United States, and in the light blue, the proportion of individuals who are affected by MPX. And what you see pretty consistently here is that communities of color, Black populations, and Hispanic populations are overrepresented in the cases of MPX. I dare say, and I hypothesize with 99.9% certainty, that white populations are over-vaccinated for MPX as compared to communities of color. And so we have a lot of work to do here, not only with MPX generally in the population and in the gay and bisexual population, but something that we've been talking about at the School of Public Health for a long time, the notion that LGBTQ people are not the same. We are not one group of people. And so we are diverse in multiple forms of our identity. And so we have to target messaging to address those multiple intersectional identities that we hold. Poll question number one, everybody. Are you ready? Michelle, are you ready to do the poll question number one? I don't hear Michelle, and here it is. Here's the poll question. I'll read it aloud. Monkeypox first infected a human during which decade? 1950s, 1970s, 1990s, or 2010s? And people are answering. I love this. Sort of like watching like the track and field championships a few weeks ago, which I'm a huge fan of. So the majority of people, let's close it right now, Michelle. The majority of people have answered, 60% have answered the 1950s, 35% the 1970s, 3% the 1990s, and 2% the 2000s. I'm going to go to my next slide so we can stop. Can we remove that, Michelle, so I can go to my next slide? All right. I still seeing the poll for some reason. I'm not sure why. Maybe it's just me.
It's just you.
It's just me. Okay. But in fact, what we know about MPX is it did first appear in monkeys in 1958 in Copenhagen, and it infected people, humans, in 1970 for the very first time with a 9-month-old infant in the Democratic Republic of the Congo. So 1970s, although the disease has existed since the 1950s. We know as of yesterday, the Biden administration, with some of our friends leading that group, have called for monkeypox to be called a public health emergency. This is an incredibly important moment because not only does it increase resources and funding, but it also allows for the giving of vaccines in a slightly different manner so that more people could get vaccinated fully at the beginning. We have several resources available to you that you can see here, and these will be available in our slides that we send back. But those are live links, so that we were originally thought we were going to give you a sheet, but given the way things are changing every single day, we thought we'd just give you these links. And finally, as a pitch to my own work and the work of my team, you will see right here a study we are currently doing on vaccination in LGBT populations in New York and New Jersey. There's a set of questions in there also about MPX. So if you're interested in doing this survey, just scan that QRS code, or when we send you the slides, feel free to share this widely, and you can take part in the study where there's an opportunity to win a $30 gift card. So I'm going to stop my comments right there, and I am going to now have the pleasure of introducing to you my colleague, Dr. Rafael Perez-Figueroa. Dr. Perez-Figueroa is the Associate Dean for Community Engagement and Public Health Practice at the Rutgers School of Public Health. He's an associate professor, someone I've worked with for a very long time, who just joined us this last winter from the University of Kentucky School of Public Health. And before Rafa starts, we're going to ask you a poll question. And the poll question is... Poll question, Michelle? People with monkeypox can transmit the disease only when they develop a rash, true or false? By the way, everyone, we have 464 participants, and thank you all for being here and being so actively engaged. It's amazing.
And we are seeing right now that 83% of the participants are responding false, which is correct, and I will be talking about that. Thank you, Dean Halkiris, for your introduction. I'm Rafael Perez-Figueroa. Buenos dias to everybody. I will now be sharing my slides. So please give me a reaction if you can see my screen right now. And let me show these slides. And as Dean Halkiri says, I will be presenting about the clinical presentation of this disease. And before I begin, I want to emphasize on how this is a condition for which we have great tools, such as vaccines and treatments. We have had enough time to respond, but yet at the same time, we are struggling in our public health response. And I think that is critical for us in this panel to discuss why that is the case. People with MPX present typically with flu-like symptoms. These include fever, headache, muscle pain, swollen lymph nodes, tiredness, respiratory symptoms such as congestion and cough. These symptoms normally present 1 to 2 weeks after exposure to the virus. 1 to 4 days after the flu-like symptoms, a rash develop. That rash normally starts in the mouth. From the mouth, it goes to the face, and from the face to the rest of the body. And this presentation that I'm describing is what we know that is the typical presentation based on previous outbreaks. Now, in the context of this particular outbreak, we are seeing a lot of variability in terms of the clinical presentation. And part like of what we are seeing is that the rash might start like in the genital areas. It can be a localized rash that happens like in just one part of the body. It might or might not present with flu-like symptoms. And this variability poses challenges to the diagnosis of the disease. Another challenge that we are seeing is that the diagnostic tests are currently being carried in the public health labs, which are at a level of bureaucracy and more time than like when you do a lab test in a commercial lab. It is important to highlight that normally when we think about a rash, we think about like a disseminated reaction. In the context, in the case of MPX, this is like a very distinctive lesion. This is how the lesion look like. The rash follow different phases. It starts flat, it then raise, it fills with liquid, it scab, then the scabs then falls, then new skin is formed. Throughout the whole process of having a rash, from having like the flu-like symptoms, if the disease manifests in that way, people will be infected. And we know that this process takes between 2 to 4 weeks. The rash is described as itchy and painful. Some people describe this rash as the worst pain that they have ever experienced. And the rash can be infected. This rash can present as confluent or hemorrhagic. There's other complications of the disease that we know, such as like inflammation of the brain and neurological symptoms. But despite that, the fatality rate is like very low. In the context of other outbreaks, it have been between 3 to 6%, meaning like the number of people who die of this disease, but that doesn't make this disease like less important, right? It seems like that it's important to understand that we have 2 vaccines available for this disease. Both of the vaccines are live virus vaccines. One of those vaccines, the Jynneos vaccine, is like the one that is currently being widely administered. This vaccine requires 2 doses with 4 weeks between each of the doses. People are considered to be immune after 2 weeks from the second dose. Although there's benefit on just having 1 dose of the vaccine, there's a level of prevention that is achieved with just doing that. The other vaccine that we have available is the ACAM 2000. This is a vaccine that have the capacity of replicating in the body. It has several side effects. It's a vaccine that have been approved for smallpox, and to be administered, it is considered to be an investigational treatment, and to be administered, it requires like additional forms. We are currently administering this vaccine as pre-exposure prophylaxis for people who work like in public health labs, and also as post-exposure prophylaxis for people who are like known contacts of somebody who have experienced MPX, and also for people who are like at high risk in areas with no monkeypox cases. We have treatment available. The treatment is also considered to be investigational, and that requires like additional forms to be completed. which is a burden currently for, like, for example, community clinics. So some people experience a waiting time of up to 2 weeks for receiving the treatment. That is expected to change. Like recently, the CDC changed the guidelines for the treatment, and that is expected to increase the access. But still accessing treatment is a challenge that we need to consider. When we see the response that we are having, the public health response, and all what we are doing for addressing this particular public health crisis, we need to think about health inequities throughout that process. We need to think about, like, who are the people who are, like, most under-resourced, and like how what we are doing is impacting those people. And when we think about the number of hours that takes, like, to schedule a vaccine, who have access to good quality healthcare services, and the implications of that in the context of this particular public health crisis, that is very salient. And another point that I want to make is that we cannot think about this public health crisis without considering HIV, substance use, mental health, and good access to healthcare services. So I will pass it now to my next colleague. Thank you so much.
Let me take my mute off, and thank you, Rafa, for sharing those thoughts. I want to take some questions because there are some questions from the audience here. And the first one is, and so somebody had asked also, just this is a more of a technical issue. There will be a closed caption available when you have the video that's going to be made available after the session is over. Why is monkeypox disproportionately affecting LGBTQ population, and how can we reduce? What can we help educate to reduce the stigma? I am so sorry about that. Let me tell you an answer that I have shared, and then I'm going to ask either Bobby or Quincy or both to share their thoughts on this also. But remember, in May of this year, the entry of the disease manifested. The disease manifested in an event in Portugal and in Western Europe that was primarily catering to LGBTQ people, gay and bisexual men in particular. Again, remember, it's gay and bisexual men who are being predominantly affected. It just so happened that it entered there. It could have been a church picnic. It could have been a baptism. It could have been a straight wedding. It could have been a quinceañera. It could have been any of those things. But in fact, it entered there. And as a result, and I remember sitting at the time and going, uh-oh, there's Americans there. I know it, right? As a result of that, what ended up happening is it got spread to the LGBTQ population, to gay and bisexual men in particular, and that's why it's there right now. I'm going to toss the baton to Bobby and or Quincy to see if they would like to add anything to that.
I think something that people need to keep in mind is that the LGBTQ population, like specifically gay, bisexual men, there's a lot of dance culture and party culture and like club culture that involves a lot of dancing and being up against each other, like rubbing against each other, and again, not even looking at the sexual aspects and such, but there's a lot of body contact. And at these different like parties, events, weekends, so on and so forth. So that definitely can, again, why I feel like why we're seeing the spread so quickly and so, what's the word? Widespread and such. Quincy, I see your hand is up.
Yeah, so I mean, I just wanted to add to that, and thank you, Dr. Hakidas, for opening up to Bobby and I. Really, when we're talking about this particular outbreak, you know, we can look at COVID as a really great example of how small our global community happens to be, right? So people that know me well know that my husband's from South Africa, and it is very easy for many people that have a blue passport to just get on a plane and go anywhere across the world at ease. And so when you think about the single event that occurred in Portugal, yes, when you say there's at least one American that's there, the implication of what it looks like to cross international boundaries in an international airport with thousands of people that you come into proximity with, and then land in your own home, and also have proximity to, likely you live in a metropolis with thousands or millions of other people, the likelihood of virus spreading is really simple, right? And so this could have been any event, as we said. It just happened to be in an event where queer people were gathered together. And again, how we happen to socialize and commune. And given how in some ways we're isolated from other people in society, it makes sense that our particular connections that we have lead us to be most vulnerable to this virus.
Yeah.
I am so grateful to Bobby and to Quincy for their comments here. And I just want to add, I think it's really important for us to make sure that we are clear. This is not a sexually transmitted infection. I had been press after press, radio interview after radio interview, where people keep focusing on sexual relations, the kind of sex that gay men had. And I'm just over it. The fact of the matter is, you heard very clearly from Bobby, and you heard it very clearly from Quincy. We are intimate with each other. We dance with each other. We take our shirts off with each other. And as a result, it is transferred that way. If we continue to make it about the kind of sex that gay men have, that some people are insisting on doing, some providers are insisting on doing, we will stigmatize, right? And so we have to lift it up. Dr. Perez Figueroa, Rafa, did you want to add something to that also?
Really quickly, I just want, to emphasize the same. I think that we can put an emphasis on many different things. And one of those things that we can put the emphasis is about how this community have organized, how this community is advocating for accessing prevention and treatment and getting informed. And we have a lot of experience doing that. And we are seeing a lot of community organizing that makes me feel proud of this community. But I think that another very important highlight of this crisis is that this is a health condition, one more time, for which we have vaccines, that we have treatment, that we have time. But what we are seeing is a health system that there's a multiplicity of approaches that lack coordination, that have a problem with infrastructure. And in the past, it was COVID. Today is monkeypox. We don't know what is going to be in the future. So why not, rather than putting the emphasis on the population, we put the emphasis on that public health system and how we can strengthen that to be able to address public health crises that are important for the populations that we care about, right? So I just want to bring that point, and I know that my colleagues are gonna continue talking about it.
I love that. Rafa, thank you for that. And I hope you're all our listeners here, or all over 500 of you here, are recognizing we want this to be interactive. And it's more about this session, this hour and a half is more than about just the virus, right? Viruses don't outsmart us. We get dumb. So there are lots of, Bobby, I'm going to get your hand in a second, but I want to ask Rafa to just answer one of the questions here on the side, which is from Rashida, who asks, are these vaccines new or have they previously existed?
No, that's a really good question. These vaccines are not new. They have existed for a long time. Actually, some of the information that we know about their effectiveness comes from previous outbreaks and from animal studies. A question that have been raised, and I believe that is a very valid question, is about the effectiveness of those vaccines in the context of the current outbreak. And we are lacking data. Still, the data that we have says that we have a good opportunity of preventing this disease with the current vaccines. So there's so much that we can learn about this, but these are not new vaccines.
And to Rafa's point earlier, and I want to ask another question, Rafa, and then I'm going to toss it back to Bobby, and then I swear I'll come to Leslie. But, Rafa raised the issue of syndemic before, the idea that diseases fuel each other and social conditions fuel those things. And, we have, these health inequities. And I think it's an incumbent upon us to demand that our providers and our departments of health provides these services, testing and vaccination in models that I think New Jersey is actually doing right, which is, at community-based organizations. I can tell you in New York City, the other place where I live, the vaccines were rolled out I rallied to have them available in communities of color in parts of the city that were tailoring to Black, gay, and bisexual men. But what the Department of Health didn't do right was that they didn't check residents. And so what ended up happening was that a bunch of white guys, and white guys are fine, went up to these neighborhoods and sort of hogged the vaccine. So we've got to be very mindful. And I know Hyacinth and VNA and NJCRI are doing God's work in trying to get shots in the arms of all people, regardless of their race, ethnicity, culture, background, and what have you. Bobby, tossing it to you. You had your hand up.
No, I just wanted to add in just it kind of hit us right during summer where a lot of our events, traditions, and communities gather, different bear weekends and tea dances, and these are all it's not as simple as saying, oh, why can't everyone just stay home and not do these are family gatherings essentially, and it's we can't give leeway for, for instance, religious holidays and such for people gathering and not understand that the LGBTQ community, we have these specific events and community gatherings that are really integral to our mental health and our well-being and such, especially after, past several years of lockdown and COVID and such.
Thank you, Bobby. I'm going to do one more question for Rafa, and then I'm going to pass the baton to Leslie. And this is a good question, and one that I've been asked a million times too. Those who were vaccinated for smallpox, like me, born before 1972 in the United States, can they be considered to have some immunity for MPX?
Yeah.
Rafa?
So there have been discussion, and there's evidence that suggests that having that vaccine confer some level of immunity. Still, those people should go and get vaccinated, right? So we know that we are not clear on what will be that level of immunity and whether that will be protective to this particular disease. Another aligning question is to what extent people who get the case, whether they can be reinfected. So a lot of people are asking about that. That is unlikely. We know that that is unlikely with the smallpox and with similar virus. And currently there's a couple of cases in which they are questionable cases. But what we know about that is that is very unlikely. I also want to highlight something that you say about reaching to under-resourced communities. And I think that beyond being careful, you say about how we need to consider all these people in these communities. I think that is important for us in the public who are public health professionals to be intentional. It's not just about making sure that we reach to communities of color and to under-resourced communities, but we need to have targeted approaches to make sure that those populations have the access that they need, and that those approaches are likely to be effective in preventing this disease. I want to keep emphasizing that because it doesn't happen by random, right?
Right. And I think what Rafa is saying, and I think what you're hearing all of us continue to reinforce, and I hope there are folks who are listening to us who have some authority in this, is you have to be intentional. Otherwise, you're going to continue to perpetuate diseases like this in marginalized, stigmatized, under-resourced communities. So you have to be proactive, not reactive. And on that note, and Leslie, before I turn it to you, I'm going to say that there is a question from Keith that asks about why are we calling MPX an STI if and he asks, they ask to be if it's spread through, if it's not really just spread through sexual contact. I'm going to introduce now my colleague, Dr. Leslie Cantor. Dr. Cantor is the chair of Urban Global Public Health here at the School of Public Health. She has been working with us for several years and has worked in infectious disease, but is also one of the nation's leading researchers on women's reproductive rights and on maternal and child health. And we are lucky to have her here as part of the school, because while we're dealing with this, we have the Roe decision we're also dealing with. There are many public health issues that affect our lives. And so I'm going to turn it over to Dr. Cantor. And I think we're going to start with a poll question, right, Dr. Cantor? And the question is, which of the following activities could transmit monkeypox? Choose one of these answers. Kissing, skin-to-skin contact, being born, all of the above.
And thanks for your participation. And you all know the academics' tricks. You're seeing that could. Doesn't mean always will. Great, okay.
Leslie, all yours.
Thank you so much. Let me get rid of the poll. Thank you so much for inviting me to be part of this panel. I am going to be talking about transmission and prevention. And the piece of my background that Dr. Halkitis didn't lift up is that I am a sex educator first and foremost. So we are going to get into this distinction about that while MPX is not an STD, and I'll talk a little bit about that, it can be transmitted through sex. And a friend said to me yesterday, she asked me a couple of questions. She said, what I love about you is that you can answer questions about sex just like you're giving me a recipe for a quinoa salad. So I believe that is what brings me to this panel today. So let me share a couple of slides. Of course, starting in the wrong place, as PowerPoint is wont to do. So a couple of things that I do want us to keep in mind and will ask you to give me grace about is that the science on the current MPX epidemic is obviously in process. As you saw, rather than giving you the typical handout, Dr. Halkitis said, here's a bunch of links because we are going to continue to learn more. And it doesn't mean we're lying to you now. We are telling you the most up-to-date science that we possibly can. So I have put dates on my slides. This is going to be very important in this case because I do think that these slides will be able to be updated and will likely be outdated very quickly. And then I just want to set my intention. We actually just talked about public health people being intentional. So I want to make sure that people know the spirit in which I share this is to provide information that people can use to keep themselves and their partners safe, their patients safe, in the presence of, and I am willing to do one finger point here, what I'm going to call another failure of the public health and preparedness system. And I think probably all of us might have different things we'd nominate as examples of that failure, but certainly letting hundreds of thousands of doses of that Jynneos vaccine expire. There's no way to not call that a failure of our public health system. So with that, let me tease out a little bit about STDs. Now, I do want to really start with, I have spent my whole career trying to reduce stigma about all the kinds of sex that people have and STDs. And honestly, I feel like if we could get rid of all of that stigma, we wouldn't be worrying as much about this distinction. That said, a little bit of fun facts about STDs. Generally, something is classified as a sexually transmitted disease when sex is the main route of transmission. An example that I think is helpful in this case is Zika. So Zika is something that can be transmitted very efficiently from sex, not considered a sexually transmitted disease because it is actually transmitted more readily and more frequently by mosquitoes. So there you go. You get you're getting MPX with a chaser of Zika now. In the past, in countries where MPX has been endemic for years, the main route of transmission seemed to be contact with infected animals, likely rodents from scratches and that kind of thing. However, it is very clear from when it was endemic and certainly now that skin to skin, and let's think about, while yes, Great dancing is one way. Sex is another way that people get skin to skin with each other. And I'm going to be really clear about that. So to put a finer point on that, because somebody also earlier this week, when I said you can get it from sex, said, you can? Well, why don't they just say that? Well, I think there are a couple reasons. One is we're dealing with the stigma problem, and the other is we're dealing with a society where we are so uncomfortable talking about sex. So let's posit that almost all sexual activities with a partner include skin-to-skin contact. There are things you can do. Mutually masturbate 6 feet apart. That's one thing people have said people could do to prevent MPX and COVID. Not super fun, not what most people choose to do, but sure. I want us to remember what Dr. Perez Figueroa said. The rash, or in this case, sometimes this is appearing as just one lesion, not many lesions, which when we hear rash, you tend to think of a lot. Some people are presenting with just one lesion. These are appearing very frequently around the anus or in the anus, on the penis, in the groin. I'm not going to make everybody try to figure out how easily they can see all of those parts of their body. They're not easy to see. So people may not even realize that they have one of these, and you can have them or get them in the mouth. We know that MPX is present in saliva. So I am just going to translate this. It means that anal, vaginal intercourse, oral sex, and activities like rubbing against someone can transmit MPX. Kissing is a possible route of transmission. It's going to be very hard for us to ever sort out if kissing alone would transmit it, because let's face it, we all, everybody, whoever you are, whatever your identity, we tend to do several things when we are engaging in sexual activity with another human being, not just one thing. Now, one thing people ask is like, if it's not an STD and we're not calling it that, are condoms important? Well, some people are like, Cantor, you have been saying condoms were important and since dinosaurs roamed the earth. So of course, I'm always going to say condoms are important, but why? Let's think about what we know about MPX and how it's presenting in this current epidemic. It is presenting on the genitals in many areas. Those are areas of the body that are very sensitive. And so it can be very painful to get a lesion or a rash on the penis, in the anus, around the vulva, in the vagina, in the mouth. So use a condom, and then bonus, that will also help with other STDs, which PS are also on the rise. All right. Here's this piece that we're trying to sort out still, and the science is in process. Could semen or vaginal secretions alone transmit MPX? Well, you can find MPX in semen, but Dr. Halkitis taught me earlier this week, not something everybody's boss will teach them. You can actually find evidence of 27 different viruses in semen. Again, it doesn't mean it is the main route of transmission, but I will say to you, I'm not sure it really matters, because in general, to get semen in your body, you're going to have some kind of skin-to-skin contact. All right, end of sex, onto surfaces, not as fun, also something we're hearing a lot about. You do see MPX on the surfaces in hospital rooms in which there is a patient being treated for MPX. It's really unclear whether those fomites are likely to be a main route of infection. I'm sure you all remember during COVID, and even in some places now during COVID, there was a lot of worry about surfaces, but with MPX and orthopox viruses are hardier than many other viruses, but it's unlikely, I think. But this is why you get reminders like, keep washing your hands. Listen, there's so many things you can prevent from washing your hands, so we should just do that. And then we've been hearing about towels and bedding. Again, this is a hardier virus than some others. So all you need to do if you're infected, you have a household, somebody in your household is infected, just wash towels and sheets, hot water, detergent, and just a shout out to my healthcare partners. Regular hospital infection control should be totally sufficient related to MPX. And then lastly, I feel like one of the things that is getting short shrift is once somebody is infected, there are things you can do to make it worse or not. So a couple of quick suggestions for people if you do get infected or are infected now. Don't use contact lenses. You really don't want to get this virus in your eyes. Be really careful shaving. It's super easy to spread this around. And again, some of those lesions are not always easily visible. You know, once they get really prominent, it would really hurt to shave over them, but you can spread this around. It is probably going to make sense to abstain from sex other than that kind I talked about. If that's of interest to you, there's some things you could do, but you do want to be careful during an active infection. And then if you have a household contact with MPX, there are some suggestions about masking, distance, disinfection. This should all be very familiar to us. I'm actually going to stop there because I want to make sure that we have time for a couple of questions. Thank you.
Leslie, thank you for your insights there and for being so clear about all of this. I think it's like we get into this very strange space with STIs and what's not an STI and all of this stuff. But I really appreciate it. And I do want to, I just thought to add one more thing to Leslie said, because I think it's really critically important to remember, COVID still is going on. You still should be washing your hands. You probably should get a booster this fall when we have the new versions of the booster available. We're not still dealing with that virus. We're still dealing with HIV. We're still dealing with higher rates of gonorrhea and chlamydia and syphilis than we've seen in years. So all of those things exist. But there's a question from Ida that I really think is intriguing, and I want to pose it to the whole group. And Ida asks, I work with children, and I am particularly concerned about the risk MPX will present when children start school. Remember, we're just a month away. Children socialize different than adults. And as somebody who taught kindergarten, I know they're on the floor rolling around like, licking each other, right? Is it anticipated, you think, that MPX will become the same threat that smallpox was when smallpox was mandatory for attending school for a reason? Any thoughts on that? Anyone? I see Rafa.
Yeah, I can jump on that. I think that that's an important question, because something that we know clinically is that when children get infected with monkeypox, they they have severe cases. We don't have the same tools for preventing this disease among children at the time. There's research that is being conducted in terms of whether the vaccines can be approved for children. But it's very important to protect children, pregnant women, and immunocompromised people. So anything that we can do in order to address this particular public health crisis at this point will be very important.
Thank you for that. And I have a question I want to target to send to Leslie from one of our former SPH students, so a proud alum of our really amazing school, Anna May, who asks, I'm curious if it's recommended to avoid trying on clothing in stores, especially thrift stores. What do you think about that, Leslie?
Yeah. So I guess I would go back to actually, where are we in the course of the epidemic right now? So even though it is spreading quickly, 7,000 cases in the entire country is not a widespread generalized epidemic. And one thing I always get concerned about is, first of all, people being anxious about things they don't really need to worry about, and not getting the information and the resources to the most affected communities. So at this point in time, I wouldn't worry about trying on clothing in a store. If this became incredibly widespread, might I reassess that? Sure. I myself am trying to stay out of any unnecessary indoor spaces because of COVID. So that's again, you always want to be layering all of these pieces together.
And Leslie, I just will tell you all, is my COVID-19 super ego. So when I tell her stuff like, oh, I'm going to the Imagine Dragons concert, in Chicago, she's like, gets all nervous for me. And I remind her that it's outside and I'll wear a mask and I've got my boosters, but she sits on my shoulder here reminding me these things. So thank you, Leslie. I'm now going to turn it over to my colleague, Bobby Lowry. I have had the pleasure of first meeting Bobby when I came to Rutgers some over 5 years ago now. For those of you who might not be aware of it, I started my 6th year here as the Dean of the School of Public Health, which is kind of incredible. Bobby works at the VNA in Asbury Park. He's a harm reduction coordinator. He is an activist. He is a scholar. He sits on this interesting space of activism and practice and, community service. And he's going to speak to us today about the work that's going on in community-based organizations, his role, and also what it's like, quite frankly, to be a young gay man right now in the middle of another pandemic. Bobby, all yours, my friend. We're going to start with the poll. We're going to start with the poll question, right?
Yes.
Poll question, yes or no? I think the LGBT community is concerned with the threat of monkeypox. I love this question.
A lot of yeses, a few nos.
And we're going to end the poll right now. And the majority of folks, nearly 100%, say yes. Bobby, toss to you.
Yes, thank you so much, Dr. Halkias. Hello, everyone. I'd like to start off everything by asking all of y'all to send me good energy and vibes. And I'm going to send it back to y'all. It is Friday. We're going to have a good weekend. It's summer. Yeah, absolutely. I just looking at the poll, majority of people were saying that they do think the LGBTQ community is concerned about monkeypox, and I definitely do see that just from where I work. As mentioned before, we're one of the sites for the vaccinations, and every single day we're booked. Like we're doing appointment only and we don't have enough vaccines. So it's very good to see the community's response to immediately do what they can to protect themselves. But again, working for a community-based organization in public health and such, definitely working with people and kind of giving guidance on what they should or shouldn't be doing has been again, it's a new thing. It's kind of like COVID was slapped on us. The same situation. Working with specifically with gay and bisexual men. I've been getting a lot of questions asking, hey, like, should I cancel my trip? What if I can't get vaccinated? And as a harm reductionist, I always tell people I can't give you a definitive yes or no answer. There is no definitive yes or no answer. I can explain to you what your risks are, and you can make that choice yourself on whether or not to expose risk it essentially. Bottom line is like even talking about sexual health period, anytime you engage in any sexual activity, you're putting yourself at risk no matter what. There is no such thing as safe sex, because bottom line is there is no definitive possible way that there's absolutely no way that you would get an STD, a cold, the flu, monkeypox. I really like to talk to individuals about kind of weighing the pros and cons. So, and especially hopefully we're coming out of the worst of COVID at this point. A lot of people's mental health is really I don't want to say damaged, but really, really hurting right now, and really looking for something positive, like Bear Weekend at P-Town, or going to a leather event in San Francisco, so on and so forth. And I tell people, hey, look, I can't tell you, like I said, what is or isn't going to happen. However, if you're going to a big dance party, then maybe if you were feeling like any symptoms like fluish or anything like that, maybe don't go. Skip out on that. Or if stick with your friend group and make sure you're talking and kind of explaining to each other what's going on and such. Bottom line is a lot of these people are looking for connections that they previously had at these events and such, and it's the mental health part is something that I think a lot of times is missed in these situations, especially as practitioners are talking, like they might not necessarily know like all the facts and all the details, and really kind of looking at it through the lens of that lens, or harm reduction lens, or even a trauma informed lens, that hey, you know what, people have been through a lot of stuff for the past couple of years, so um it's don't tell people like, hey, you have to go into quarantine again. um um Again, I tell my friends right now, like, hey, let's kind of reduce the amount of um anonymous hookups that you go to, but hey, like if you have some steady fuck buddies that you have that you want to go to, by all means, as long as those communications are happening. Definitely try to get the vaccine as soon as possible, but it's specifically since it's summertime, a lot of trips have already been planned. And I am I frozen? No, okay. Sorry, my internet is iffy. Um, it's also interesting seeing the different reactions from the younger generation versus the older generation. A lot of the older generation are honestly have a lot of trauma around their community being targeted, or being mostly affected by different um, viruses and such. So kind of explaining to individuals, hey, look, you can still have a quality level of life. Like you don't have to completely like isolate yourself and not talk to people, not see a friend, and so on and so forth, and kind of explain that we're luckily at a different place right now. Also, that monkeypox isn't at this point as quite as deadly, or so on and so forth. I think also, so I'm going to talk about drugs because I always talk about drugs, as that's my specialty. Um, Talking to people, individuals, about their substance use, and again, using more of their harm reduction tools and reducing points of exposure, like reducing sharing pipes, sharing if you're doing lines of coke with your friends, don't all share a dollar bill. I mean, that's what I've been telling people since COVID itself, because it's A, dollar bills are gross, don't ever do that, but B, it's a great way to transmit COVID. And especially with monkeypox, like I think we've covered, that it's not just sexually transmitted, that it can be transmitted through other means such as body contact and such. Maybe bring your own supplies, bring your own pipe, and don't share with everyone else, in like going to sex party or drug party, so on and so forth. I think for all the providers out there, definitely having, again, those discussions and kind of looking at it from a harm reduction lens can really increase the trust you have with your patients, as well as again, encourage people to take more steps. Because if you give them kind of the ultimatum of, hey, you need to stay home or you're going to get it, a lot of people kind of get the, well, I'm going to get it anyway, so I'm going to go out there and have fun and not worry about the consequences and such. Meanwhile, having kind of a discussion of, hey, these are ways that you can, protect yourself and your community, or reduce the risks of those, definitely encourages people to essentially try more. Um, as a young gay man, and my younger generation, a lot of individuals are pretty much asking me for, hey, like what, like, is this, um, am I gonna die from this? Again, I can't give a definitive answer, but it's yes, you can still like go see your friends. However, you're putting yourself at risk as well as your friends. So kind of make that decision on your own. And I use that I use that philosophy in general for people with sexual health and such. Do we have any questions, Dr. Alquitas?
We do, but I do want to actually highlight something that you said, which I think is really, really important, which is, and it's a theme you've been hearing all along here, which is, this notion of harm reduction, right? The things you can do to keep yourself safer, the people who probably are at most risk, right? If you're, I am a 59-year-old gay man who is not out dancing every night. I am probably at less risk than my dear colleague here is a much younger man than me who may be out dancing many nights a week. I don't know. I'm not assuming anything, Bobby. But I think that you have to make these decisions about who's at risk and why you're at risk based on what you know about your life and about your social circle. There are a bunch of questions. Let me just see. There are a bunch of questions about vaccines, and let me see if that can answer this question. Oh, this is an interesting question. I don't think there is an answer. This is from an anonymous attendee who's asked about safety plans for the fall semester at Rutgers. There aren't any plans right now. We're still thinking about plans for COVID, I think, also at the same time, because that's still going on. So stay tuned for that. The university finally put out a message last week about that. So that's really, really critically important. But I think that, to Bobby's point, and, and I think to the point that others have raised, let's think about who's at risk, why you're at risk, if you need the vaccine, right? When you need the vaccine and what have you. And we'll come back to wrap it up with all of this stuff later. But I want to now turn it over to our last speaker of a session, who's going to be talking about vaccines, which is the main thing that we can do. And I think Bobby said this, we've got people we have a population that is interested here, that wants to be vaccinated, that is willing to be vaccinated, yet somehow we drop the ball on all of this, right? So hopefully we'll be able to change that. And I'm hoping that Quincy will be able to give us some insights into exactly what is going on with the vaccine. Quincy is the LGBTQ manager at the Hyacinth Foundation, and for full disclosure, I am on the board of directors of the Hyacinth Foundation. I have the pleasure of working with Quincy and Axel and Kathy O'Brien and all those other great folks at Hyacinth. So Quincy, I'm going to turn it over to you, and we're going to start with a poll question once again. How does the state of New Jersey determine who, this is perfect, eligible for the monkeypox vaccine? Because it's a lot of the questions have to do about eligibility. Let's do it.
All right, thanks for your responses. I love looking at this, like.
All yours.
Perfect. Okay, so it seems like we have majority of our individuals have the correct answer. The agencies, such as ourselves at Hyacinth and state officials, will follow the guidance set forth by the CDC, the federal guidance that we have on determining the eligibility of vaccines. So yes, there may be some discretion that may be had at a local level about what that eligibility criteria looks like. But for the most part, we do follow the guidance from the CDC. So that's great. A few of you said that Governor Murphy sets that. He follows the guidance from the CDC according to the health officials at the DOH. So thank you for the poll answering. I want to now share my slides, so give me a moment. And like my fellow presenters, if you could just indicate to me that you can see what needs to be seen. Perfect. All right. So my name is Quinty Belbignon. I wear many hats in the community, one of which is I'm the statewide LGBTQI plus prevention manager for Hyacinth Foundation. I'm the program manager for Project Living Out Loud based in Jersey City. And so I'm going to give you a little bit about what we do, a response that includes both the governmental, an agency, and a community response to MPX. So first, I just want to give you a breakdown of that's really relevant for the discussion that we've been having today. The first confirmed case of monkeypox in the US, as we said, was back in May 19th of this year, all the way to looking at yesterday's declaration from the Biden administration of MPX as a public health emergency. A public health emergency in which there are cases in 48 states, the District of Columbia, as well as Puerto Rico. And we can see the case number having increased to about 7,000 persons. So to note, on July 21st, which is a day after New Jersey began its vaccine program, there were about 2,500 cases of confirmed monkeypox or MPX throughout the United States. We're more than beyond twice that number, right, within the last 2 weeks. And it's important to know, particularly when we talk about our public health response and we talked about vaccines, that the previous MPX outbreak in the United States took place in 2003. It occurred for about 3 months of time, was localized to 6 states, and there were 71 cases. And we did not have any necessarily known human-to-human infection as far as the spread. So this is all new to us, and then in some ways not at all. So we'll talk about that. So these are slides that you might have seen before if you have gone to the CDC and wondered what the eligibility criteria is. So there are 2 different criteria for what we have for indications of monkeypox vaccination. One is called PEP. This is familiar to many of us working in the HIV workforce, post-exposure prophylaxis. So this is for someone that has a known exposure to monkeypox infection. And there's a best case and a next best case scenario into how soon people should have access. So the best chance is that, you know, if someone is given the vaccine within 4 days of exposure, that's the best chance to reduce any potential infection or symptoms from developing. The next best scenario would be for someone that is from 4 to 14 days of time. That's why a lot of our questionnaires when we do the screening is talking about, have you had a known contact? Have you done X, Y, and Z within 14 days? That is indicating those eligibility and the best case scenarios for practice. What is not beneficial, and we can have a different conversation about, is for individuals who already are showing signs of monkeypox infection, right? And so for that treatment, as Raphael laid out earlier, is the best option for people to do. And that treatment option is getting better as far as access. So another category that we're looking at, and this is the expanded category. This is why you're seeing a wide call for certain people in our community to get vaccinated at this time. And I'll talk about that in the next slide as well. So this is called what we call expanded PrEP, expanded PEP, or PEP plus plus, or just those signs, right? The PEP and the plus sign. So if you've seen this, then you know we're talking about individuals within a population, within a community in which there are known monkeypox infection. They may have not necessarily had contact, but again, it's uncertain what that contact may be, right? So I really want to talk about this aspect of community viral load. It's really important. I know that there are some of my HIV colleagues here on, so you should know this. So community viral load just really simply is talking about the cumulative, so the majority, the totality, the total amount of a virus that's within a particular community or population. So when we talk about community and population, we're referring to a geographic location, quite possibly, or also a group of people. So keep that in mind. It is measurable, and in many ways, it helps guide what our public health response is, right? It helps guide understanding case counts that exist and where, for instance, vaccines should be distributed. I want to make note to some place that I find home, which is Jersey City. In Jersey City, if you have ever been, you know that it is a gateway to New York City itself. There are so many aspects of our connections that take place between the Hudson River, whether it's tunnel, bridge, however people get across. And it makes Jersey City residents and people that work within Jersey City or socialize there particularly vulnerable to MPX, given that New York City has been really center of this current outbreak in the United States. So people have said before that when New York sneezes, we get a cold. And indeed, that has occurred. I want to now talk about the agency response here. And as you can see with the slides, there's some titles of "This is what we do." And I want to give you some instance of where that comes from. So our executive director, Kathy O'Brien, she weekly sends out just an email to everyone within our teams. And it's a really great refresher to kind of bring us together and have a commitment to our work that we do and the mission that we have here at Hyacinth. And so just recently, she shared something which came from our harm reduction director, Alicia, in regards to, why is Hyacinth doing what it does when it comes to MPX. And so I'll just share this quote. She says, "We respond to crises that create issues for our communities that we serve and who are part of the Hyacinth family. So of course, this is what we do." So in addition to having, being a part of the extended PEP vaccination program, there's a lot of legwork that goes into running an agency response when it comes to MPX. So first and foremost, it's very important that we talk about advocacy. So besides the three CBOs that specialize in HIV/AIDS in the state, the VNA, NJCRI, and ourselves, who have been doing the work as far as getting shots in people's arms, there are other organizations such as Garden State Equality that have really been doing great advocacy to make sure that we talk about access, to make sure we talk about equity and all the conversations when it comes to this vaccine. In addition to that, vaccine awareness is one of the most very important things that we can do at this time. Raphael discussed the aspect of being intentional about that. And we found ourselves in many ways being behind the ball, right? So lately we have been a lot more intentional in the type of pathways in which we talk about the vaccine. And I want to give shout out to just 3 people particularly that have been really helpful, particularly in Jersey City. So Eric of the Gayborhood Facebook group for Jersey City, thank you. Ms. Harmonica Sunbeam, thank you very much. And Ahmed from the group Fade to Black, I really appreciate you. So thank you as well. And there have been community partners as well that have supported in making sure that people that they know that need access to this vaccine the most or need information on this vaccine the most, get that from us or get that from other resources. The last thing that I really want to talk about is risk reduction. We do know that vaccination is one way to help prevent monkeypox and MPX. However, there are many other ways in which we can all play a part. So I'm going to give a shout out to my team. I'm not going to list names. I don't want to embarrass people. You know who you are. You're in the picture. In addition to that, some of my team from LOL, I really appreciate you as well. Our Hyacinth teams across the state have really stepped up to help be a part of the mobilization. So one of the most important things that we talk about within public health is focusing on how education and awareness is really a pillar and is vital to disease prevention itself. So one of the most important things that we can do if we understand that vaccination currently is for post-exposure. We can think about what people happen to do in a pre-exposure landscape, right? Why not cut off MPX at the pass? So these are really great tips, and these will be shared on what people can do both before and also after they may encounter vaccination. So let's keep things real. And I think Bobby laid this out. Leslie, thank you so much for this too. Introducing the conversation of sex. Because yes, MPX does come into the intersection of sexual health, and it's very important to make some distinctions here. It's very important to emphasize that sex feels good, at least mostly feels good. And it should feel good. Let me just say it that way. And let's be honest that somebody is going to be sexing. In fact, someone may be sexing right now listening to us. So we want to be able to make sure that they have the best tools possible, the most information possible, most accurate information, as I should say, possible, to make the most informed decision on their sexual health needs. So if people are going to engage in sexual activity, we can talk about harm reduction and risk reduction strategies that would be most important and most relevant to them. So I really want to move off of the agency response and the federal response and talk about some things that people in the community have done that I've seen. And I really also would like for you all that are listening to share resources with us about what you've seen as far as MPX mobilization across the United States and even the globe. One of the resources that I found was a vaccine locator. And so as you can see here, this site would be a volunteer sign up. So there are people in the community that can do their due diligence by looking up where vaccines are available in their community and listing it on this particular listserv for people. That may include any feedback about eligibility criteria or how to get to those certain spaces. Again, this is really helpful to being able to community build in this moment. I want to share also this other resource, this one that's on the left. These are licensed clinicians that exist for an MPX support group. It is a free, F-R-E-E, free resource for people who need it. They are very receptive to emails, and they will get back with you probably within 6 hours of time. So understand that if you do need this resource or you know someone who does, that this is available to them. On the right, I just want to share a little bit about the aspect that there is a rising number of information and resources that can be found online. I am 40 years old, so I kind of move between the aspect of traditional resources in the community and going to places and calling them, and also being able to use Dr. Google and find for myself. So one of the resources that I think is really excellent for this time is Leo Herrera, which is a queer HIV historian. We are of the same age, so I find his perspective quite interesting as being in a middle generation that occurred within the HIV pandemic. One specific thing that is noted with him is he does what is called a bumpy ride podcast that's dedicated to monkeypox. And yes, us queer people can laugh at the face of danger. So it's called the Bumpy Ride podcast. I believe that there are about 6 episodes currently. And Leo is chronicling what is going on with MPX while he is currently visiting Berlin. Which was a height in Europe of the outbreak. So some additional resources, there's Dr. Carlton, which some people may know as like the butt doctor, right? That really talks about sexual health and the aspect of physical and sexual pleasure. And he has some videos that includes being able to talk, particularly for our medical provider community, how to talk about MPX, how to discuss treatment options for people. And as we know, pain seems to be a really big indicator that people are saying that they're facing when it comes to MPX and those symptoms. And so how do you relieve pain, which not only is something that people physically can feel, but also emotionally impacts them. Also, you can see here on the left, monkeypox vaccine support. This is a great comprehensive resource that there are resources shared from all over the United States that kind of go into the site. As you can see, there's also some stuff for Canadians or neighbors to the north. So it's really important. I follow these sites. I recommend that if you want more information that you do as well. I think they provide a lot of perspective and depth to our conversation. So I'm about to end, and I really want to be able to talk to you about the aspects of some equity and social justice issues and where that comes into play with the vaccine. So you see the title here. I'm not really going to read it because you can read it for yourself. And you know, there are plenty of articles that have taken place just this week before a public health emergency was announced about what our federal response has been to MPX and what vaccine scale up could look like, but has not. So we know the aspect that vaccine availability and access is not equitably distributed. And we know particularly when there's less of things, the least of us, right, get the less of the end. And so I don't need to spell that out for you, but I know you can feel the parable together. So one of the things that we're really talking about in this moment is the aspect of what privilege it is to be vaccinated currently. When we look at the state of New Jersey and we think about around 3,000 individuals have been vaccinated for MPX currently. We think about the larger number of people who are still waiting in line or who are still not aware that they should possibly get the vaccine. And so I would really want to speak mostly to us privileged few and talk about what can we do as far as our own community responsibility to support people in this time. We've moved from an aspect of, in the past 3 weeks with the New Jersey response, from people who were concerned, that was the first week of people that were wanting to get vaccinated, to a panic. And so it really requires a community response and a collective effort to address how to heal from this moment. This provides an opening for me to talk about the aspect that we have vaccine clinics that we're doing in Jersey City. We are looking for volunteers. I'm not sure about the other agencies that are within our vaccine program, but we are looking for volunteers. So I want to emphasize that. We're doing a vaccine clinic tomorrow in Jersey City. This is the way that you can contact me for more information if you'd like to volunteer. We need as many people as possible, even if that includes bringing water. We thank that. We absolutely thank you for that. Other things in which we want to, you know, ask community to lend a hand is, you know, sometimes the locations tomorrow will be in a space in which there are several transit options, but it is away from the main train station in Jersey City. So, you know, people have been taking Ubers to get there. You know, who wants to carpool? Who wants to handle those particular things? We also need to be mindful of individuals who are battling MPX as we speak, right? So people that do the HIV workforce are really savvy about buddy programs. In many ways, that's how we began as AIDS service organizations. And so that's still needed. I've gotten calls and I've called people who are sitting at home and isolating for 3 weeks of time. It's really important that if you know someone who is experiencing MPX, experiencing COVID, that you reach out to them, that you check in on their mental health, their physical health, that you see what can be tended to them, right? So if it's meals and medical supplies that they need and they don't feel comfortable, or they say they shouldn't leave the house to do those things, right? Then please make sure that they're taken care of. I think one thing that we may find ourselves dealing with also is an aspect of income support. MPX, particularly as we see it now, you know, people may be weeks without being able to leave their home. For some of us, I'm very privileged to be able to be in my office or offices and also do my work here in Newark in my home. That is not the case for most people in the United States, and is not the case for most people that are experiencing MPX. So I want you to really think about, you know, intentionally, what is your role? As we as agencies, as scholars that do this particular work, think about being intentional. I also think there's a call for the community to do so. So that's where I'm leaving you.
I love everything you said, Quincy. Thank you for that so much. We have some time for questions. I just want to add a couple of things to what Quincy was saying, because it so triggers for me. I'm in the middle of trying to write a book right now about what we didn't learn from HIV that should have prepared us for COVID and should prepare us from monkeypox. And and I think a lot of the problem is that we continue to focus on disease as being purely medical, purely biomedical, right? And the medical profession really hasn't caught on to this fact yet. And we continue to treat people like as they are just like vessels for pathogens instead of vessels that have emotions and social realities and structural conditions that compromise their health. And so one part of our advocacy and part of our work is to continue to push the medical profession to think outside its comfort zone and what disease really, really is. And it's not just about infection and a virus or pathogen. So thank you for the opportunity to say that, Quincy. We have about 10 minutes left. And thank you to all the speakers for this amazing forum this morning, where we've spoken honestly and openly about these issues, which I think is really critically important from people I think participants you will see are really passionate about this and really actually care about the people that we're working with. We are part of this community. We are advocating for those we see around us who don't have access. So we are asking you to join us in this fight in trying to get needles and care in the arm in for those who need it the most, who don't know how to turn to those resources. All right. Let me go through my list. There's a lot of cool questions here that I want to just toss out to you. I'll throw out some to the whole group. I'll throw some targeted. We've got about 10 minutes left, five to 6 minutes left, and I want to do them. So the first thing I think is you, Quincy, and I think I know the answer, but I want you to answer it. Can first responders and their families get the MPX vaccine now?
I haven't seen that indication yet. I do know that just in our task force meeting yesterday, we were discussing the aspect that the CDC will expand eligibility. I haven't received that notification yet.
Right. So stay tuned for that. I mean, I think that the messaging has been confused from the CDC about who's eligible for vaccine, who's not eligible for vaccine. We know, but this is part of being part of a community. We know some people are more at risk. Let's make sure they get it into their arms first. Let me go to the next one. The next question is maybe a Rafa question. HIV and monkeypox, are immunocompromised people at greater disadvantage for infection or more severe symptoms? Rafa, can you tackle that one?
Yeah, that's totally correct. So immunocompromised people are at a higher risk. People who have a higher number of comorbidities of other health conditions are at a higher risk. So it's very important for us to consider who are the people who are most vulnerable and make sure that they can access vaccines and prevention, but that is something to take into consideration. Children, pregnant women also are at a higher risk of having complications from this disease.
Right. And I think, Rafa, these things are so complicated, right? There's, somebody who's born before 1972 and has HIV, has smallpox, but that person is also older. And as an older person is probably more at risk. So these algorithms are not simple. And so we have to be thoughtful about it. This is an easy question. Thank you, Rafa. An easy question for me, which is, yes, these resources will be made available by mail, by email to people who are participated. I did the monkeypox, I did the first responders. Here's a question from my friend Robert Nolan. And I think the answer is no, but I'm going to ask Rafa this question too, and maybe Leslie. Is there a self-testing kit for MPX?
No, that I know. Actually, that is a significant challenge right now, because when people go to a doctor with symptoms and signs of it, the doctor need to call the Department of Health, take the sample, send it to a public health laboratory. And as we are seeing more cases, this is going faster. But at the beginning, that was very burdensome, right? So that is how the testing is taking place. There's no self-test at this point. It doesn't happen In some places, it can happen in commercial labs, but they need like to have like a specific authorization for being able to carry these tests. But that is part like of the challenges that we are facing with this condition.
One of our participants said people who were vaccinated, this is I want to, and Leslie and I to answer this one together. People who were vaccinated still got COVID. What would the difference be with this vaccine? I'll toss it and I'll start and I'll toss it to Leslie. COVID's a new virus. It's a novel virus that we're only beginning to learn about. MPX is a virus that's existed since the 1950s. We know a lot more about it. So I think it is not apples and oranges here between the COVID vaccine and MPX. Leslie, what do you think?
Yeah, I mean, this is a vaccine that we already had for smallpox, which is actually more contagious, more serious. So we have experience with this vaccine. It's thought to be about 85% effective. So honestly, I think that the challenge right now, some people might have seen, they're actually talking about doing a slightly different administration of the Jynneos vaccine and doing it under the skin versus completely intramuscular, because you wouldn't need as large of a dose. Right now, it's really about, we've got to produce more vaccines, we've got to get it out there, and that will allow for some expanded eligibility as well.
Question for the whole group. This is kind of just a fun question from Matthew. Are there specific sports we should encourage our patients to consider avoiding now, or perhaps in the near future as we have MPX in our mix? Bowling seems fine to me, maybe, I don't know, or tennis, I don't know. I mean, but anyone else have thoughts on it? I would say wrestling, probably not such a great idea right now. Anyone else?
Yeah, it seems like that, like if we think about like the logic of this disease, anything like that involves like a lot of skin to skin contact will be riskier. One more time, going back like to something that like Leslie say, are we at a point in which like we need the whole population should be concerned about this disease? That might not be the case at this point. So it's important like to keep this in proportion, right? And you know, like that would be my recommendation about that.
Thank you. So being mindful of the time, we're at 12:30, but I will say this, and I'm gonna like put my friends on the spot here. First of all, let me thank Rafa and Leslie and Quincy and Bobby and Michelle Edelstein, our Marcom communications person, put this all together. This is a work in progress, this outbreak. If I'm being honest, and I think, you know, what we're going to be in a month, I don't know where we're going to be in a month, but maybe at that point in time, we have another one of these and update you yet again on where we are, because this is going to change rapidly, like COVID changed rapidly. And hopefully it will be better now that it's a state of emergency, but we don't know that. So stay tuned for other opportunities to engage with us about where we are and anything else that we're learning. As Michelle, as I indicated earlier, the slides will be available. We thank you all. Over 400 of you stayed the whole time, which is really incredible, and a testament to my colleagues and their magnificent ideas. Thank you all. Have a wonderful, wonderful, wonderful weekend. Stay safe, volunteer, fight back, act up. You know what to do. We know how to make this all better. Have a wonderful, wonderful day. Bye.